Hey everyone, welcome to the human side of hospitals. I'm so glad you are here. And now on this channel, we don't just talk about medicine, we listen to real people, to patients, to doctors, nurses, caregivers, anyone who has an unforgettable hospital experience. The hospitals can be places of healing, hope, sometimes even heartbreak, and every story has something to teach us. That is why I'm starting this, just to give people a space to share, to be heard, and to remind us that behind every hospital wall are human beings with stories worth telling. Now, here's where you come in. So, if you've ever been a patient, if you've worked in a hospital, or if you've supported a loved one through their hospital journey, I would love to hear from you. And you can send me a short video, audio, just write your story down. Or if you would like to sit and chat with me, you can join me live on Zoom. And all you have to do is just fill the form in the description below, or you can send me an email. And it doesn't matter where you are from, who you are, or whatsoever. You are welcome wherever part of the world you come from. And before we dive in, don't forget to hit the subscribe button and turn the notification bell. Basically, not to miss these incredible voices from around the world. And a quick disclaimer before we start: these stories, their personal stories, shared with full consent, and we are here just to inspire, educate, and raise awareness. One thing is those who want to remain anonymous, well, for the sake of confidentiality and privacy, altered some of their voices into AI voices. And note that even the advice shared in these videos or in these experiences, they are not a substitute for medical advice. Always remember this. And if you have health concerns, always speak to a qualified healthcare professional. All right, let's dive into today's story.
I'm Dr. Benjamin Thornfield, Chief of Interventional Cardiology at Presbyterian Heart Institute in Charlotte, North Carolina. Or at least I was until I handed in my resignation 3 weeks ago. For 17 years, I've dedicated my life to the intricate mechanics of the human heart. I've performed over 3,000 catheterizations, implanted countless pacemakers, and reconstructed coronary arteries that most physicians would consider inoperable. My fellowship at Johns Hopkins, my board certifications in both internal medicine and interventional cardiology, my publications in the Journal of the American College of Cardiology, all of it built on a foundation of unwavering faith in medical science and measurable reality. Presbyterian Heart Institute sits on the 8th floor of Mercy General Hospital, a sprawling medical complex that serves the greater Charlotte metropolitan area. Our cardiac catheterization lab is equipped with the latest Siemens Artis Z biplane system, capable of capturing real-time images of coronary circulation with unprecedented clarity. Every procedure is recorded, every measurement documented, every anomaly investigated until rational explanation emerges. That's how it's always worked. That's how I believed it would always work. I've seen arterial walls calcified beyond recognition. I've witnessed hearts so damaged they barely qualified as functional organs. I've watched patients flatline on the table only to revive them through precise medical intervention. But what I'm about to tell you is the one case that shattered everything I thought I understood about cardiac medicine and ultimately drove me to abandon the profession that defined my entire adult life. It began on a Tuesday morning, October 15th, 2024. I remember the date precisely because it was the day my world stopped making sense. The morning started like any other. I arrived at the hospital at 6:30 a.m., grabbed my usual black coffee from the physician's lounge, and reviewed the day's scheduled procedures with my team. 3 routine angioplasties, 1 complex bypass consultation, and an emergency catheterization that had come in overnight. Dr. Sarah Chen, my most trusted colleague and fellow interventional cardiologist, met me outside Cath Lab 2 at 8:15 a.m. We'd worked together for 8 years, and I trusted her clinical judgment implicitly. The overnight case is interesting, she said, handing me a manila folder thick with preliminary reports. 43-year-old male, no significant cardiac history, presented with classic STEMI symptoms around midnight. EKG shows massive anterior wall involvement. But here's what's strange. His troponin levels are completely normal. I flipped through the lab results, frowning. Troponin is a protein released when heart muscle dies. During a major heart attack, which the EKG clearly indicated this patient was having, troponin levels should be through the roof. Normal levels made no medical sense. Equipment malfunction, I suggested. That's what I thought. We ran the labs 3 separate times on different machines. All normal. Even had the night tech recalibrate everything. The patient's name was James Whitmore, insurance adjuster from Gastonia, married with 2 teenage daughters. No history of drug use, no known cardiac risk factors beyond mild hypertension. According to the emergency room notes, he'd collapsed at home around 11:30 p.m. while watching television. His wife called 911 immediately. Paramedics found him conscious but experiencing severe chest pain, radiating down his left arm. Textbook presentation. Vitals? I asked. Stable now. Blood pressure 130/85. Heart rate 78 and regular. Pain resolved completely about an hour after admission, which is also unusual for this type of infarction. We entered the preparation area where James Whitmore lay on a gurney, looking remarkably peaceful for someone who'd supposedly suffered a massive heart attack 6 hours earlier. He was awake, alert, and showed no signs of distress. His color was good. No pallor, no diaphoresis, no shortness of breath. "Good morning, Mr. Whitmore," I said, introducing myself. "How are you feeling?" "Much better, doctor. The chest pain is completely gone. To be honest, I feel like this whole thing might have been a false alarm." I listened to his heart with my stethoscope. Regular rate and rhythm, no murmurs, no extra sounds. His lungs were clear. Peripheral pulses were strong and equal. Everything about his physical exam was completely normal, but the EKG didn't lie. The ST elevation pattern was unmistakable. A classic anterior STEMI, indicating complete blockage of the left anterior descending coronary artery. The vessel cardiologists call the widowmaker because blockages there are often fatal. "Mr. Whitmore, I need to be direct with you. Your electrocardiogram shows evidence of a significant heart attack. We need to perform a cardiac catheterization immediately to identify and treat any blocked arteries." He nodded calmly, almost serenely. "I understand, doctor. Whatever you think is best." Something in his tone struck me as odd. Most patients facing emergency cardiac catheterization show at least some anxiety. James Whitmore seemed completely at peace, as if he were discussing the weather. At 9:20 a.m., we wheeled James into Cath Lab 2. The room hummed with familiar efficiency. Monitors displaying vital signs, the sterile steel of the catheterization table, the massive C-arm of the imaging system positioned overhead like a mechanical vulture. My team consisted of Sarah, 2 Cath Lab technicians, Robert Kim and Jennifer Walsh, and our scrub nurse, Patricia Gonzalez. All seasoned professionals who'd participated in thousands of similar procedures. We positioned James on the table and began the standard prep. Local anesthesia to the right groin, sterile draping, insertion of the arterial sheath. His vital signs remained rock steady throughout. Blood pressure 128/82, heart rate 76, oxygen saturation 99% on room air. "Ready for contrast injection," Robert announced from his position at the imaging controls. I threaded the catheter through James's femoral artery, up the aorta, and positioned it at the opening of his left main coronary artery. This is routine procedure, something I'd done thousands of times. The contrast dye would illuminate his coronary circulation on the monitor, revealing any blockages or abnormalities. "Injecting now," I said, pressing the syringe plunger. The contrast flowed into James's coronary system, and his arteries appeared on the monitor in stark detail. I expected to see a complete occlusion of the left anterior descending artery, the only explanation for the EKG findings we documented. Instead, I saw perfectly normal coronary arteries. No blockages, no narrowing, no plaque buildup. The circulation was pristine, Better than most men half his age. That can't be right, Sarah murmured beside me. I repositioned the catheter and repeated the injection. Same result. Moved to the right coronary artery system. Perfect. Every vessel was wide open with excellent flow. Robert, are you recording this? Yes, doctor. High definition digital capture, same as always. I stepped back from the table staring at the monitor. The EKG still showed massive ST elevation consistent with complete LAD occlusion. But the angiogram revealed coronary arteries that looked like they belonged in a cardiology textbook. Absolutely normal. Patricia, can you pull up the EKG from this morning? She brought the tracing to my viewing station. The ST elevation was unmistakable, massive. The kind of pattern that indicated extensive heart muscle death. But the coronary angiogram showed no possible source for such damage. Mr. Whitmore, I said, leaning over the patient, how are you feeling right now? Perfect, doctor. No pain, no discomfort. I feel wonderful, actually. His voice carried that same strange serenity I'd noticed earlier. His eyes were closed, but not in a way that suggested sedation or distress. More like peaceful meditation. I repeated the left-sided injection a third time, moving the catheter to different angles, ensuring I hadn't missed anything. The arteries remained perfect. No disease, no spasm, no abnormality of any kind. Sarah, I need you to look at this. She moved to my position and watched as I performed another contrast injection. Her expression mirrored my own confusion. Ben, this is impossible. Those EKG changes require complete vessel occlusion. There's no way to generate that pattern with normal coronary arteries. Could it be artifact? Equipment malfunction? We verified the EKG on 3 different machines. Besides, look at the morphology. It's too consistent, too classic to be artifact. I glanced at the monitors. James's vital signs remained absolutely stable. Heart rate 76, blood pressure 130/85, no arrhythmias. His oxygen saturation was 100% without supplemental oxygen. Then Jennifer Walsh, our senior cath lab tech, said something that made my blood run cold. Doctor, look at the monitor. I turned to see what she was pointing at. The real-time EKG display showed normal sinus rhythm, no ST elevation, no abnormalities, completely normal. That's not possible, Sarah said. The EKG was abnormal 30 minutes ago. Patricia, pull up the archived EKG from this morning. She accessed the digital records. The ST elevation pattern was still there in the archive files. Massive, unmistakable, clearly documented. But the current EKG was completely normal. I stood there staring at 2 different electrocardiograms from the same patient, taken hours apart. The first showed a massive heart attack, the second showed a perfectly normal heart, and the angiogram showed coronary arteries incapable of producing either pattern. Mr. Whitmore, I need to ask you some questions. Have you ever had any heart problems before? No, doctor. Any family history of cardiac disease? No. Any medications, supplements, recreational drugs? Nothing. Have you ever experienced anything like last night's symptoms before? For the first time since I'd met him, James Whitmore opened his eyes and looked directly at me. His gaze was calm, but somehow unsettling, as if he knew something I didn't. No, doctor. Last night was the first time. I completed the procedure and we transferred James back to the cardiac unit for observation. The angiogram had taken 45 minutes instead of the usual 20 because I'd repeated every injection, checked every angle, verified every finding. Sarah and I retreated to my office to review the case. Ben, I've been doing this for 12 years. I've never seen anything like this. It has to be equipment error, multiple equipment errors. The EKG machines, the cath lab imaging system, the lab equipment, all malfunctioning in exactly the right way to create a coherent but impossible clinical picture? She was right. The probability of simultaneous equipment failures creating such a consistent pattern was essentially 0. What about the patient? Could he be fabricating symptoms somehow? You can't fake an EKG, especially not those specific changes. And he didn't even seem that concerned about being here. I called down to the lab and requested another complete cardiac enzyme panel on James Whitmore. If he truly suffered a massive heart attack, the troponin levels would be elevated for days. The results came back an hour later. Troponin, undetectable. CKMB, normal. LDH, Normal. Every cardiac marker completely within normal limits. I also ordered an echocardiogram to assess his heart function. Patients who suffer anterior wall MIs show characteristic wall motion abnormalities that persist for weeks or months. The echo was perfect. Normal wall motion throughout, excellent ejection fraction, no signs of any cardiac damage whatsoever. At 2:30 p.m., I went to check on James. He was sitting up in bed reading a magazine, looking completely comfortable. "How are you feeling, Mr. Whitmore?" "Excellent, doctor. When can I go home?" His question was reasonable, but something about his demeanor continued to unsettle me. Most patients who'd undergone emergency cardiac catheterization showed some anxiety, some concern about their condition. James seemed almost bored. "We'd like to keep you overnight for observation. Given the unusual nature of your case, I want to make sure we're not missing anything." "Of course." I performed another physical exam. Heart rate 72, blood pressure 125/80. Heart sounds normal, lungs clear, no peripheral edema, neurologically intact, alert, and oriented. "Mr. Whitmore, I need to be honest with you. Your case is unusual. The EKG this morning showed changes consistent with a heart attack, but all our other tests suggest your heart is completely normal." He looked at me with that same calm, almost knowing expression. "What do you think that means, doctor?" The way he asked the question, not with concern or curiosity, but as if he were testing my understanding, made me profoundly uncomfortable. "I think we need more data," I said. That evening, I stayed late to review James's case with our entire cardiology team. 7 physicians, all board certified, all with years of experience. I presented the EKG findings, the angiogram results, the laboratory values. The consensus was unanimous. The case made no medical sense. Dr. Michael Rodriguez, our electrophysiologist, examined the EKG tracings in detail. These are classic anterior STEMI changes. Massive ST elevation in leads V2 through V5. Reciprocal changes in the inferior leads. This pattern requires complete occlusion of the proximal LAD. "But the angiogram shows normal coronaries," Sarah added. "Then one of the tests is wrong," said Dr. Patricia Lawson, our senior partner. "Equipment doesn't lie, but it can malfunction." "We verified everything multiple times," I said. "Different machines, different technicians, different contrast batches. The angiogram is accurate." "Then the EKG was wrong." "We ran the EKG on 3 different machines and got identical results." The room fell silent. These were physicians who'd collectively seen tens of thousands of cardiac cases. None of us had encountered anything like this. Dr. James Patterson, our chief of cardiology, finally spoke. "Ben, I want you to repeat the angiogram tomorrow. Use different equipment, different contrast, different everything. And I want continuous cardiac monitoring on this patient throughout the night." "Already arranged," I said. As the meeting broke up, Sarah pulled me aside. "Ben, there's something else. I've been thinking about this all day, and I remembered a case from about 6 months ago. Different presenting symptoms, but similarly impossible findings." She described a 50-year-old woman who'd presented with heart failure symptoms. Her echocardiogram showed severely reduced heart function, but her angiogram revealed normal coronary arteries and her cardiac enzymes were normal. No explanation for why her heart wasn't working properly. What happened to her? That's the strange part. We kept her for observation, and by the 3rd day, her echo was completely normal. Heart function returned to normal without any intervention. She was discharged home and hasn't been seen since. Did you follow up? I called her primary care physician last month. She's been completely asymptomatic, no cardiac medications, living a normal life. Another impossible case. I was beginning to sense a pattern I didn't want to acknowledge. The next morning, October 16th, I arrived early to check on James Whitmore. He was already awake, sitting up in bed, looking perfectly comfortable. "Good morning, doctor. Am I going home today?" His overnight monitoring had been completely normal. Heart rate averaged 68 beats per minute. No arrhythmias, no ST segment changes. Blood pressure stable. No complaints of pain or discomfort. "We're going to repeat the heart catheterization this morning, just to be thorough." For the first time, I saw a flicker of something in his expression. Not quite concern, but perhaps amusement. "Is that necessary, doctor?" Given the unusual findings yesterday, yes. I want to make absolutely certain we haven't missed anything. Of course. At 9 a.m., we repeated the entire procedure using Cath Lab 1 instead of Lab 2. Different imaging equipment, different contrast agent, even different arterial access site. I approached James's left radial artery through the wrist instead of the groin. The results were identical. Pristine coronary arteries, excellent flow, no abnormalities whatsoever. But this time I noticed something I'd missed the day before. During contrast injection, James's heart rate didn't change at all. Most patients experience slight bradycardia during contrast injection. It's a normal physiological response. James's heart rate remained exactly 76 beats per minute throughout the entire procedure. Robert, are you seeing this heart rate stability? Yeah, Doc. Pretty unusual. Most patients fluctuate at least 5 or 10 beats during contrast. I repeated the injection, watching the monitors carefully. Heart rate, 76. Blood pressure, 128/84. No variation whatsoever. Sarah, look at this. She watched as I performed another injection. The heart rate trace was as flat as a ruler. No normal variability, no response to stimulation. Just a perfectly constant 76 beats per minute. That's not physiologically normal, she murmured. No, it's not. I completed the angiogram and began to withdraw the catheter. As I did, I noticed something that made me freeze. James Whitmore's eyes were open, and he was looking directly at me with an expression of calm satisfaction, as if he were enjoying a private joke. Is everything all right, doctor? His question was perfectly reasonable, but something in his tone, a subtle undercurrent of amusement, made my skin crawl. Everything's fine, Mr. Whitmore. We're almost finished. That afternoon, I received a call that changed everything. Dr. Angela Foster, an emergency physician I'd worked with for years, asked me to consult on a cardiac case that had just presented to the ER. 38-year-old female, came in with classic heart attack symptoms. EKG shows massive inferior wall STEMI, but her cardiac enzymes are normal and she looks completely comfortable. I felt a chill run down my spine. I'll be right down. The patient was Rebecca Morrison, a high school teacher from Matthews. Her EKG showed massive ST elevation in the inferior leads, indicative of complete blockage of the right coronary artery. But like James Whitmore, she appeared remarkably calm and comfortable. I rushed her to the cath lab immediately. The angiogram revealed perfectly normal coronary arteries. By the time we finished the procedure, her EKG had returned to normal. 2 impossible cases in 2 days. That evening, I began a systematic review of our cardiac catheterization records from the past year. What I found horrified me. 7 additional cases. 7 patients who presented with clear evidence of major heart attacks but had normal angiograms, normal cardiac enzymes, and mysteriously rapid recoveries. All of them had displayed the same unusual calmness, the same strange serenity that had unsettled me about James Whitmore. All of them had maintained perfectly stable heart rates during catheterization, and all of them had been discharged home with normal hearts and no explanation for their presenting symptoms. I contacted each patient's primary care physician. The follow-up reports were identical. Complete cardiac health, no medications, no symptoms, no limitations. It was as if they'd never been ill at all. I spent 3 days poring over the medical literature, searching for case reports of similar presentations. I found nothing. No documented instances of EKG changes as dramatic, with normal angiograms and normal enzymes. I consulted colleagues at Duke, UNC, and Emory. No one had seen anything like it. On October 19th, James Whitmore was discharged home with a clean bill of health. His final EKG was normal, his echo was normal, his stress test was normal. According to every objective measure, his heart was perfect. But I knew something was fundamentally wrong. That night I called James at home. Mr. Whitmore, this is Dr. Thornfield. How are you feeling? Wonderful, doctor. Never better. I wanted to follow up on your case. Your presentation was quite unusual, and I'm wondering if you've experienced anything similar before. There was a long pause before he answered. Doctor, do you believe that medical science explains everything about the human body? The question caught me off guard. I believe it explains most things, yes. Most things, but not everything. Another pause. Mr. Whitmore, Is there something you want to tell me about what happened? I think you already know, doctor. You just don't want to admit it. The line went dead. I couldn't sleep that night. I kept thinking about James's final words, about the 8 impossible cases, about the pattern that defied every principle of cardiac medicine I'd spent 17 years learning. The next morning, I made a decision that surprised even me. I called in sick, something I hadn't done in over 5 years, and drove to the medical library at UNC Charlotte. I spent the entire day researching not cardiac pathology, but the history of unexplained medical phenomena. What I found was disturbing. Throughout medical history, there have been documented cases of patients presenting with clear evidence of severe illness who spontaneously recover without explanation. The literature calls them medical miracles or spontaneous remissions, but the descriptions were eerily similar to what I'd been seeing. Patients who seemed to know more about their condition than they should. Patients who remained calm in situations that should have caused anxiety. Patients whose physiological responses during procedures were abnormally stable. Most unsettling were the reports from physicians who'd encountered multiple such cases. Many had eventually left medicine, claiming the experiences had shaken their faith in medical science. I found 17 documented accounts spanning the past century. Different specialties, different hospitals, different countries, but the pattern was always the same: impossible presentations, normal findings, mysterious recoveries, and physicians who eventually abandoned their careers. That weekend, I received another consultation request, this time from Dr. Richard Chen at Carolinas Medical Center. Ben, I've got a case that's right up your alley. 52-year-old male, massive anterior STEMI on EKG, but normal enzymes, and he looks great. Sound familiar? My blood ran cold. I'll be right over. The patient was Thomas Brennan, a construction foreman from Concord. His EKG showed the same massive anterior wall changes I'd seen with James Whitmore. His demeanor was identical, calm, peaceful, almost serene. I performed the catheterization myself. Normal coronary arteries, perfect circulation, no explanation for the EKG abnormalities. As I withdrew the catheter, Thomas looked directly at me. "You're Dr. Thornfield, aren't you?" "Yes, how did you know?" "James Whitmore mentioned you might be the one to do this procedure." My hands began to shake. "You know James Whitmore?" "We've never met in person, but we've talked." "I don't understand." Thomas smiled, the same knowing, peaceful expression I'd seen on James's face. "Doctor, there are things happening in your hospital that medical science can't explain. You've seen them. You know they're real. The question is, what are you going to do about it?" I finished the procedure in silence and went home without speaking to anyone. That evening, I sat in my study, staring at the wall, trying to process what I'd experienced. 9 cases now, 9 impossible cardiac presentations, and somehow these patients were connected to each other. I called James Whitmore again. This time he answered immediately. "I was expecting your call, doctor." "Mr. Whitmore, I need to understand what's happening. These cases, they're not medically possible." "No, they're not." "Then what are they?" Another long pause. "Doctor, have you ever considered that human consciousness might be more than just brain chemistry? That the connection between mind and body might be deeper than medical school taught you?" "I don't understand. Your instruments measure the physical, but there are aspects of human experience that exist beyond the physical realm. What you've been seeing are intersections, places where the unmeasurable touches the measurable. That's not possible. You've seen the evidence with your own eyes. You've documented it, verified it, confirmed it with multiple colleagues. The question isn't whether it's possible. The question is whether you're prepared to accept that your understanding of medicine might be incomplete." I hung up the phone and sat in silence for an hour. The next Monday, I requested a meeting with Dr. Patterson, our department chief. "James, I need to discuss my recent cases." I presented all 9 cases, complete with EKGs, angiograms, laboratory results, and follow-up data. He listened without interruption. When I finished, he was quiet for a long time. "Ben, what exactly are you suggesting?" "I'm suggesting that we're encountering phenomena that medical science cannot currently explain." "Equipment malfunction." 9 separate equipment malfunctions, all creating identical patterns, unusual presentations of known conditions. There are no known conditions that produce these findings. Then what's your explanation? I took a deep breath. I don't have one. That's the problem. Dr. Patterson leaned back in his chair. Ben, you're one of our best cardiologists. Your clinical judgment is impeccable. But what you're describing sounds like what? Like you need some time off. I took a medical leave of absence and spent 2 weeks at home trying to make sense of what I'd experienced. But the cases kept coming. Sarah called me 3 times during those 2 weeks to describe additional patients with identical presentations. By the time I returned to work, the number had reached 14. Each case followed the same pattern. Dramatic EKG changes indicating major heart attack, normal angiograms, normal cardiac enzymes, rapid recovery, and mysteriously calm patients who seemed to know more than they were saying. I began keeping detailed records, documenting every aspect of each case. The data was consistent and reproducible. The findings were impossible. On November 15th, I encountered my 15th case. This time, something different happened. The patient was Maria Santos, a 45-year-old nurse from our own hospital. I knew her professionally. We'd worked together on dozens of cases over the years. Her EKG showed massive anterior wall changes. Her angiogram was normal. Her behavior was the same calm, knowing serenity I'd seen in all the others. But as I was completing the catheterization, Maria spoke directly to me. Dr. Thornfield, you've been chosen to witness something important. These experiences aren't random. They're being shown to you for a reason. I almost dropped the catheter. Maria, what are you talking about? You've seen 15 of us now. Each time you've documented phenomena that medical science says are impossible. Each time you've been forced to confront the limitations of what you believe. This is some kind of psychological manifestation. No, doctor. This is something else entirely. Something beyond the scope of your instruments and your training. Then what is it? She looked directly into my eyes with an expression of infinite compassion. It's a reminder that human experience extends far beyond what can be measured in a laboratory. That consciousness, healing, and the nature of reality itself are mysteries that science has barely begun to explore. That evening, I made a decision that would have seemed impossible 3 months earlier. I wrote my letter of resignation. I couldn't continue practicing medicine when my fundamental understanding of human physiology had been shattered. How could I confidently interpret EKGs when I'd seen EKGs that lied? How could I trust angiograms when angiograms had shown me impossibilities? More importantly, how could I continue to claim expertise in a field where I'd witnessed phenomena that made no scientific sense? My resignation sparked considerable discussion within the medical community. Several colleagues tried to convince me to reconsider, attributing my decision to stress or burnout. But I knew the truth. I had encountered something that medical science couldn't explain, something that challenged the very foundations of my professional worldview. The cases didn't stop after I left. Sarah continued to update me. By the end of December, they documented 23 similar presentations. A pattern had emerged, but it wasn't a pattern that belonged in medical textbooks. 3 months have passed since I left Presbyterian Heart Institute. I've been offered positions at several other hospitals, but I've declined them all. How do you return to a profession when you've seen evidence that its fundamental assumptions might be incomplete? I spend my time now reading, not medical journals, but philosophy, consciousness studies, the intersection between science and the unexplained. I'm trying to understand what I witnessed, what those 15 patients were trying to show me. Sometimes I wonder about my colleagues who are still practicing. How many other physicians have encountered similar phenomena? How many have chosen to rationalize what they've seen rather than question their understanding? The cases I documented remain in the hospital's medical records. 15 impossible cardiac presentations that challenge everything we think we know about heart disease. The data is there, verified and documented, waiting for someone brave enough to examine it objectively. But I suspect most physicians will do what I initially tried to do: find rational explanations, blame equipment malfunctions, attribute the findings to unusual variants of known conditions. It's easier than accepting that our understanding of medicine, of human physiology, of reality itself might be incomplete. The patients I encountered possess something that medical science cannot measure. A deeper understanding of their own bodies, a connection to healing processes that exist beyond the realm of pharmaceuticals and procedures. They came to our hospital not because they were sick, but because they were chosen to deliver a message. That human experience extends far beyond what we can quantify in our laboratories. I often think about James Whitmore's final question to me. Do you believe that medical science explains everything about the human body? The answer, I now know, is no. And that's a truth that medicine isn't ready to acknowledge. The most unsettling realization isn't that I witnessed impossible medical phenomena. It's wondering how many other cases like these occur every day, in hospitals across the world, dismissed by physicians who lack the courage to question what they think they know. Because once you've seen the impossible documented with scientific precision, you can never again pretend that science has all the answers.